You ask about MRD, minimal residual disease testing, and I would say, reminder that I'm a pediatrician, that in pediatric ALL we have been using multi-parameter flow-based MRD to make clinical decisions for years, and so it is firmly established as a technique. And in Europe, again, in the pediatric ALL community, they use a different technique. They use allele-specific PCR, also very nice usability in determining ultra-high risk, because patients who don't enter an MRD negative remission in ALL, especially pediatric ALL, have a really diminished event-free survival. And actually, those are the patients that we're going to test using early CAR T intervention. So these are patients who we could be getting at first line, 3 months of therapy, still MRD positive, go on to CAR T, try to avoid transplant. That's the general idea. So I think that there's a pediatric consensus. Now, on the adult side, MRD hasn't been used that way. It's not used to intensify therapy, and adult therapies for ALL are not as complex as pediatric therapies. We have all these different phases and different chemotherapies and different combinations, and it's just quite different, pediatric therapy for ALL, even though it's the same disease, than adult therapy. But my sense from the adult ALL side is they are going toward using MRD more and more as we see a way to deliver CAR T safely in adult ALL. I think that's going to be an important part of that story. And then from a technical standpoint, so US we have US we have flow, Europe we have PCR, but now everybody has availability of next-gen sequencing as the next way to do the MRD determinations. And that next-gen sequencing is more specific, it is more sensitive. It hasn't been as clinically validated, but I can tell you on the pediatric side, the Children's Oncology Group is working intensively with the intent that we eventually go away from flow and toward this next generation sequencing approach.